Just want to give a little bit background. So this is, other than two of us, we do have our team, so many people who work with us. Some of them are clinicians, and some of them are our administrative office. So then I got this video after our last session, I believe. But it was 2 weeks ago, perhaps. And then it was a 10-minute video, and then I was on my way home, and I started watching it, listening it rather, maybe. So then you don't panic. So, well, immediately I sent that to Dr. Erkan. And then we said, well, you know, this is one of the main issues that we are having with people's understanding, and how little this understanding is happening. And this really important topic is being discussed without a specialist. Someone who's the expert on the topic is not being in that setting. And then I'm like, okay, so these guys are talking about this really important issue. No one is mentioning the most effective way of dealing with the morbid obesity, which is bariatric surgery. And then we maybe better understand what may be really happening behind the closed doors. And this wasn't a closed door, so this was right in front of the. I believe this is from BBC. So I'm going to actually share one small clip from this video, and I will build the discussion around that. Let's try and then see if everything. I'm going to need my team to send me a verification of the sound of the video. So, but let's go ahead and share what we have.
Big backlash against your appearance in the video. These critics saying that it glorifies obesity, that your weight is unhealthy, and that by appearing in the video, you're encouraging people to be overweight. And then once this critic has spoken out, a big backlash against the criticism by people saying, no, this is about accepting all sorts of different shapes and sizes, which is the camp that I'm in, as I'm sure the viewers already know. But what is your view, and how have you reacted to the criticism against you?
Well, I mean, fat people exist.
So this is our first one. This is the introduction of this. And let me actually play the second video as well.
Sure.
Okay.
But it's whether we should be celebrating a body image which is medically defined as highly dangerous. And I'll explain why. If you don't mind me just going through some stats here. You're 36 years old, you're 5'4", you're 380 pounds, 27.1 stone, and your BMI is 64.6. Now, the BMI ranges, according to the World Health Organization, 18 is underweight, up to 24 normal weight, 25 to 29 overweight, 30 to 34 class 1 obesity, 35 to 39 class 2 obesity, anything over 40 class 3 obesity, which is morbid obesity, i.e. a level of obesity which could very possibly lead to early death. Your BMI is 64.6.
So do you think that Angelina doesn't know all of this?
No, and the reason I'm saying it is so that viewers can understand the debate properly. My argument is this, is that when you are that level of morbid obesity statistically, is it right to put people like yourself into a pop video celebrating that kind of weight? And I ask you honestly, to be honest with yourself. We've had all this with Tess Holiday. She's on the cover of Cosmo, and it's all celebrated. There's no mention of it being a dangerous weight.
Honestly, if you were really
All right, Dr. Erkan. So, well, of course, watching this for someone like us, for me personally, is terrifying. Terrifying in a way that you and I, we do this show almost every Friday. And I wouldn't do this show without a clinician with me, without an expert. And I would consider myself an expert on the non-clinical side. and knowing the topic very well. But I would still, if I was invited to that show, I would definitely ask you to come with me or go there instead of me, because you would be giving better information, and it would be from the expert. But what was your take on this when you heard this introduction of the issue?
So, as you said, Kemal, this is a primetime show, through the BBC in the United Kingdom, and there are many problems with this presentation, but there is a hugely missed opportunity as well, as you said, right? So there are problems really starting with the fact that there is clear, blaming and victimization of a person who happened to be morbidly obese, right? Of course, in their view, they are trying to, highlight the fact that this person who suffers from a serious level of morbid obesity has gone to a show, celebrating her body, right? When we talk about how obesity is presented in our society, it's far more common, to see shows where people with morbid obesity are stigmatized and treated unfairly and teased, as opposed to celebration, really. So that's not a major issue from that point of view, right? And then it's a missed opportunity because, as you correctly say, they are talking, in a public forum about a serious medical problem, serious public health issue, and they're not really addressing the most important fact, which is that there is treatment available, right? There is a lot of finger pointing there, right, towards the person who is suffering from morbid obesity, right? And that is an issue. And that's an issue that we see all the time. Finger pointing, blaming, stigmatizing people with morbid obesity actually worsens obesity. It doesn't help them, right? People say sometimes, oh, if I tell them openly that they are really this and that, maybe they will do something about it, as if it was something that you can fix with a snap of a finger, right? Come on. Mm-hmm. But actually, study shows that when you stigmatize and treat unfairly or tease people who are suffering from morbid obesity, you make their situation worse because you make them more depressed. And the more depressed they are, what do? They reach out to things that make them, happy for the moment, which may be even binge eating. So obesity actually worsens when you are really highlighting their problem in such a fashion, as opposed to bringing it up as a medical issue, right? We don't talk about high blood pressure or diabetes in these terms, and yet morbid obesity is that. It is a disease. So taking the blame out, taking the finger pointing out of it, and just discussing it as a medical problem, right, would be much more refreshing and actually providing solutions. Because, as you correctly said, there is treatment for this. And it's interesting that in a show of this level, they are not bringing up bariatric surgery. They are treating bariatric surgery as if it was a closet treatment, as opposed to a very important component in the treatment of morbid obesity. Yes, so there are many issues. But of course, this, Kemal, as you know, stems from a larger problem that we have in the society, where there is total stigmatization and discrimination against obesity. Studies have shown that this actually starts very early in life. Children as young as 3 years, Kemal, have been shown pictures of children who are obese and pictures of children who are of normal weight. And then when they were asked what their thoughts are about the children who are overweight, the first things they talk about is that they are ugly, that they are undesirable, that they are not good playmates. These are children 3 years old who think that way. And then, of course, this goes on as the children grow up in school, right? In school, teachers, peers, the other kids, right? There is a lot of bullying. There is a lot of psychological and physical aggression on children who are overweight. And this goes on in the school. It goes on even in the family, within the family. Siblings or even parents are very cruel towards their children who happen to struggle with obesity. There is a study actually come out that has shown that the quality of life of children who suffer from obesity is similar to that of children who suffer from cancer. Just think about that, right? Because of the way they are treated, right? And of course, if this problem is not rightly addressed, children who are overweight are likely to become overweight in life as well. And what expects them when they enter the adult life is that the same discrimination again. If you look at the workforce, for instance, people who suffer from obesity, Kemal, are less likely to be hired when they apply for jobs, are less likely to be promoted within the same job, and they are more likely to be fired more readily, compared to normal weight peers. So this, unfair treatment, this teasing, this even discrimination goes on and on. And does it help? It doesn't. It makes it a lot worse, right? And then from a social point of view, it's just so cruel as well, Kemal. So for this show to really bring about such an important issue, and yet not to talk about the treatments available and not to be supportive towards that person who's struggling, is shameful in a way, right, Kemal? And I'm not sure whether you have more clips to bring, but
I do.
Nobody is happy to be, at a BMI of 64, because clearly their quality of life from the moment they get up from bed until they go to bed at night, they are suffering because it is physically painful to carry that much weight and carry on your daily chores.
We're going to discuss the patient perspective today. So let me actually have my other computer on so that you don't just see me. So just in terms of the program itself, we do this for our existing and the prospect patients. So there are a lot of education, especially when the provider joins us, the surgeon joins us, and then make sure that we are able to discuss so many different things together. It makes a really big difference because you don't actually get the actual expertise, expert in the field to discuss these. So as Krias and Dr. Erkan, Dr. Wen, they are the founder of the bariatric practice in Delaware, not just for Krias, but just for Delaware itself. It makes it extremely important to have those individuals as part of the program. So we actually are just going through our first renewal for our accreditation for bariatric. So what that means is that there are only 10 surgery centers in the United States, literally only 10 surgery centers out of 9,300 who is certified to do the bariatric surgery. And we are one of them. And why this is important is because it's a lot of obligations. It requires a lot of standards in terms of how we are actually handling certain things, the procedure that we have in place. And then every 3 years, they are going to come and audit our center. And then that's where we actually demonstrate that here is how we are handling our patients. This is the prep. This is during the surgery. This is after surgery. Because our obligation for after surgery is it's not over at the time of surgery. We do follow up with our patients up to 5 years, and that's part of the requirement. And I think even if it wasn't a requirement, we would still be able to. We would still would like to do that. So while waiting for Dr. Erkan, I wanted to also kind of I do talk time to time about our case conference process. So this is a discipline that we were able to adopt since almost now it's, I would say, 12 years. But in the last 3 years, one big change that we made, we turned it into a daily meeting. So our case conferences are daily. And you won't actually see this in any other part of the country. No one will have the same discipline because that's something that we customize based on the need that we have. So therefore, it's it's important for our patients to know that they will be going through a really good screening process. So that's the most important part, that we need to have a better surgery, better outcome. Not only you need the best surgeons and best facility, but you need that screening process, so that every little checkbox is being checked, and then you are prepped at the best way, so that we minimize the risk of surgery at any given time. And that's why our patients are able to go home after their surgery, 6 to 8 hours. We are able to discharge our patients. In the last 12 months, there are about 400 cases we completed at the surgery center, and then only 2, if I'm not mistaken, 2 patients, they needed to be either staying overnight, or either one of them had some personal issues, and the other one needed a little bit more oxygen. And that's very rare that we would keep anyone after the 6 to 8 hour time window. So the other thing that's important is how we are communicating with our patients. So there are full-time nurses who are part of these case conferences, who are assigned as the care coordinator. So our patients are getting the initial introduction, and we have a different database that's based on that's actually not part of our EMR, because in some cases what happens is patients are when they have to use the portal, and when we have a simple message, they have to open the message before they can see what we are asking. But with the database emails, we are able to actually send the specific emails, like saying that you need to complete your blood work, that's on subject line, you need to complete your cardiology clearance, you need to follow up with your EGD site, whatever it is, so then we make it extremely fast, efficient from that way. Now, I see Dr. Erkan is joining us. Dr. Erkan, we are live already.
Wonderful. Sorry about that.
No problem. So I did it a little bit differently this time, knowing that you are going to be there, and then I do want to post another message. So and then our audience, they know that we work with the surgeons, and then there will be unexpected, things that delays may happen, but because we understand that. So I was trying to just talk on my own, just to give.
You can do the whole thing by yourself. You know that by now. Come on.
It's not fun. That wouldn't be fun, but also that wouldn't be as credible when I have the surgeon who's experienced.
I appreciate.
Our main focus is this is not a commercial that we are running. This is education for our patient, and it's the source is important, and the source is you and our other providers.
Thank you.
We do have other events outside of our Bariatric Friday on Tuesdays at 6 p.m., second and fourth Tuesday every month. We have the full-fledged webinar of the process, and our other providers, other surgeons are actually running those on top of the support group that we are running first Tuesday of every month. So, and because there's a lot of stuff to talk about, so it's easy to kind of just get sidetracked, because if I don't have something specific, so there's so many things to talk about. So today we discuss the patient perspective. Now, we have done the patient perspective in the past several times, and I want to add something to this.
Sure.
Just to kind of, when we say patient perspective, it's kind of like, it's pretty wide there. So maybe it's not very specific what the patient perspective is. It the expectation, or is it the prep work? Is it the follow-ups? That rather than that, I want to kind of focus on the patient perspective of the actual psychology of the patient, psychological state that they are at. Because here's why I'm asking this. Here's why I do that.
Yeah.
So this week, there were a couple patients. They were about to be done, and everything that they finished, and then they were getting ready for surgical clearance, and they backed out. And then as soon as I see that, and then earlier I was explaining our daily process, daily case conferences, we see them, and we want to know why it happened. And in some cases, I'm not able to reach out to the patient. So they don't want to talk at that point. So they make a decision that, no, I'm not going to go through this. And that, if you remember the message that I sent you the other day with the patient who had, you sent me one where the patient lost about 100 pounds. And I sent you one where the patient did lose 90 pounds and then they went back up again. And then I sent you, I believe, a couple weeks ago, another one or two examples where patient came back and then they were already heavier than
Yes, you did. Very tragic, right?
So,
because that was a huge jump in the weight, right?
So now, and I want to put that in the perspective from the patient side. So what's going through in their mind, I guess, because you actually meet these patients several times before that, how we can actually change our way or what we can do better and how we can actually understand them better.
That's a great point, Kemal. That is really actually the crux of the problem when it comes to the healthcare's approach to morbid obesity, right? We have failed as a healthcare system to really strongly convey that morbid obesity is actually a disease, right? And why am I saying that, Kemal? Because it would be unthinkable, for instance, for a patient who has cancer, colon cancer, and they've been recommended to go surgery, and their doctor has sent them to prepare for the surgery, including heart, lung, and other clearances. And then for them to call their doctor and say, no, I'm canceling my surgery. That would be unheard of.
Yeah.
That would be hugely unusual. And yet we come across situations where, as you correctly pointed out, where our patients complete everything and then they back off, right? So what is the big difference here? The big difference is the perception, the understanding. And it's not necessarily the perception and understanding solely of our patients. It's actually the perception of society as a whole that has on morbid obesity, right? I will give you a very good example, Kemal, which is actually very recent, okay? One of our primary care doctors from our network sent a patient to us, and he actually sent me a message saying that that patient needed to be seen for treatment of obesity. And then at the same time, they wanted, he wanted me to look at a lesion that the patient may have on the skin, right? So the main message was it's the obesity is the message, right, from the doctor's point of view. And yet when I walked into the room and I asked the patient what the issue was that we were going to deal together, she just talked about the lesion, totally, right? And the issue of obesity actually came in much later when we talked about other health issues that the patient was experiencing. And then, of course, I delved into the issue and I said, hey, how comfortable or uncomfortable are you with your current weight? And then she said, very uncomfortable, very uncomfortable. And that became the main discussion afterwards. In other words, approaching the issue of obesity from the patient point of view, there is a lot of reticence there. They're really not ready because society has imposed so much, negative views about obesity as something that a person is responsible for, and their healthcare should not really be even concerned about that. As you know, even the American Medical Association has taken years to recognize obesity as a disease, right? So there is that perception. So we have failed really to convey this message to society as a whole that morbid obesity is a serious, serious medical problem that needs to be taken care of, right? And that actually is reflected in the statistics that we have that show that only about 1% of the patients actually that have indications for bariatric surgery present for bariatric surgery. The vast majority of patients, we don't even see them, right? So I can see the perception from the patient's point of view. So there is this reluctance there. Am I really, my family, my other friends, they're saying, oh, you can do it by yourself. What do you need surgery for? Surgery for weight loss? That's just some Hollywood stuff. That's not really, you can do it by yourself, right? Because there is this huge underestimation that obesity is something that anybody can take care of. But you and I know very well through our experiences year after year that it is not a willpower issue. It's not a appearance issue. It's a disease. It's a disease that is so resistant to many attempts to deal with it when patients try to take care of it by themselves that the most effective treatment we have right now is surgery. So there is that barrier, I see, Kemal, that really envelops our patients, and only very few patients are actually totally free of that and are able to grasp and embrace the fact that bariatric surgery is appropriate for them. So in a way, it's actually not surprising that we have patients backing off, Kemal, because there's this, there's this second thought. There is, am I really needing the surgery? Is this really something I cannot do? And they forget the many, many attempts they've done in the past, right? So there is that perception. And then on top of that, of course, immediate family members or friends or others may not be as supportive as they need to be, because even they are also influenced by the perception of obesity. So I actually think this topic is very important, Kemal, because that is really at the heart of the problem we have in reaching the population that needs to be reached and offer this treatment currently.
Absolutely. And this is one of the slides that I want to share. This is one of the patients, and it's kind of like when you put it in a graph, you can kind of see how drastic that change can be. So they, 3-4 years later, they are now 50 pounds heavier. I see a lot of those 50, 60, 70. And then now I'm going to actually share something with you. So I was watching some of the older TV shows, like from 15 years ago, when there's a jury and then someone, it's kind of like the American Idol type of stuff. It was unbelievable how mean they were towards to the person's physical appearance. Yeah, clearly, the person has the morbid obesity, and then they call the person fat. And one says, how do you think you can be a singer when you are this fat? And I'm like, film news is we cannot say that now. At least,
that's right. That's right. We've come a long way.
I think from that point, but I think from the understanding of the disease itself, there's still this perception fight where when you talk to people, immediately they're like, oh, you're just fat. Well, that's not the case. Like even with the other chronic problems, even when they are under control, they still have medication support. Like patients with diabetes, the A1C is under 6. The mistake sometimes we see rarely is patients stop taking medication because their A1C is now controlled. No, your A1C is not cured, right? Your A1C is under control. So you still have diabetes. So your diabetes is not cured. So, and this is the same thing here when the percentage is a lot higher when patients are not, sometimes patients don't take it seriously. Sometimes other people are not. Now, Dr. Rao, the one thing that I like seeing here is, and we discussed the benefits of the bariatric surgery last week. and how patients are improving, and with the 3 examples that we had. But this diagram here is explaining more than what we did last week. So we were focusing on 3-4 different very common illnesses, comorbidities that bariatric morbid obesity has. But this is amazing that patients can actually get to really good results for their other problems, because obesity, morbid obesity, is the root of all of these problems, right? So
Absolutely.
now, if you can tell us what type of surgeries that's available and why we would pick one over the other one.
Absolutely. So, by the way, Kemal, the slide you just showed, the one with the multiple comorbidities, that is really one of my favorite slides. It's from the Mayo Clinic, and it's so defined so well, really the problem with morbid obesity. You know, from the outside, you know, when you look at a person struggling with weight, you think, okay, they are carrying so much weight, their quality of life is not great, they're having difficulty carrying certain tasks. But there is much more to it. Morbid obesity really is the root cause of so many illnesses that by getting rid of it, very often you get rid of so many medical problems. That's why primary care doctors are buying into bariatric surgery so much right now, because they are tired of treating diabetes, high blood pressure, sleep apnea, fertility problems, headaches, migraines, dyslipidemia, which is high cholesterol, many other problems just separately, right? When the root cause really is morbid obesity. And the great thing, Kemal, is that when you do bariatric surgery and get rid of morbid obesity, many of these illnesses either disappear or improve considerably as well. So that's like, I love it actually, and I show it to patients quite frequently.
So, Dr. Erkan, with the making the decision is probably really important for the patients, right? So, in the past, we used to see lap band being very popular, and it's not something that we do as much anymore. But in terms of like going through these and just explaining to us why we would be getting one versus the other one, and how to make that decision, what's best for us.
Yes, clearly, Kemal, like you and I have talked in the past, the only option that is not acceptable in this day and age is to do nothing, right? To accept morbid obesity and to go on gaining weight year after year. That is totally unacceptable, right? Bariatric surgery is by far the most effective treatment we have, and any of those procedures would be better than doing nothing. Having said that, of course, certain procedures are best suited for certain patients than others. All these procedures are geared in some change on the digestive tract, right? The stomach, the intestines. If we start from the gastric band, the lap band procedure we have, which is the one you have on the left upper corner, with the lap band, what we do is we place a device around the upper portion of the stomach to decrease the amount of food the person can eat at a particular time. And the important thing about the lap band is that this tightness around the stomach is not constant. It can be changed. It can be tightened or loosened after the surgery without repeating the surgery, because of that little port that you have outlined right there. We can inject into the port. As you correctly said, this procedure was very popular about 8 to 10 years ago. We used to do many procedures, but we've come through also many problems associated with the gastric band, including the fact that there could be complications related to the band, but also the quality of life very often with patients having difficulty swallowing was a problem. And so we've moved away from that. But there is still an appeal to the gastric band. And the reason some patients really like the gastric band is that it is a relatively reversible procedure. It's a device we're placing around the stomach, and it's a device that we can remove from around the stomach as well. So there is not a permanent change to the digestive tract from that sense, although obviously every time you do some surgery around the stomach or the food pipe, you are causing some scar tissue. So it's not totally irreversible. There are certain changes that occur because of the presence of the band. But for all practical purposes, it is a procedure considered as reversible. But as I said, it's not as commonly done nowadays as it used to be. Why we would do the gastric band nowadays? Kemal, it could be a patient's preference, right? And if a patient comes in and they really feel that's the only option that they are prepared to see. It's certainly not for everybody. It doesn't apply to everybody. Is not a good candidate for the gastric band. But for patients who could be potentially good candidates, still the band is an option. The next procedure we're going to be looking is the one on the center upper procedure, and that is the gastric sleeve. The gastric sleeve is by far the most common procedure that we perform nowadays. And with the gastric sleeve, what we are doing really is we are reshaping the stomach. The stomach originally looks almost like a big watermelon, right? Very large, able to accommodate as much food as we can put inside it. And that's where we struggle, right? Because we don't feel full. The stomach can accept a lot of food. And whether we eat from sunrise to sunset, it will just accept the food. And that's the problem with excess calories. So what we do is essentially we reshape the stomach by cutting the stomach along a specific line that removes the most stretching portion of the stomach, which is called the greater curvature. Now, that obviously creates some changes physically in that the person will have a much smaller stomach now, but more importantly, many of the hormonal communications with the brain that determine the level of hunger and our metabolic rate are also related to this portion of the stomach. And when we remove it, there is beneficial effect from a metabolic point of view as well. As I say, the gastric sleeve is by far the most popular procedure. In a way, Kemal, it makes sense for a lot of people, right? When you really look at the stomach, this large organ, and then you make it smaller, it makes sense to them that it would be the way to go. It is in our program an outpatient procedure, which means patients go home the same day. And we have brought it to a level of safety, which is really, really very high currently with very, very low complication rates. In fact, the safety of this procedure is comparable to procedures like gallbladder surgery or other procedures that patients undergo even later in their life, essentially.
So, Dr. I have asked this question before, but just for our new audience to kind of benefit from it, so that one of the things that we do when we remove this plant is not just making the stomach smaller, and this is, sometimes like you are probably one of the I don't know, maybe mine is selective perception, but when you explain something to me, I really understand very clearly. So
Thank you.
So the way that I see here is this, yes, we have a smaller stomach now, but this section also is responsible for our hunger, right? If you can just explain that in the terms that I would be able to understand.
Absolutely, absolutely. So it turns out that the digestive tract is an extremely active system in terms of its ability to communicate with our nervous system, with our brain. And it communicates actively by sending back and forth messages, either through nerve pathways or even through hormones, which are little chemical messengers. Now, many of those chemical messengers that encourage us to eat are actually located in this portion of the stomach that we are removing. So that once that is removed, patients become much less hungry. In fact, many of our patients will tell you that they're not hungry any longer. And for months after the surgery, they will have to remind themselves to eat because they're not hungry.